Good morning, everybody. My name is Rebecca Picasso, and I am the Program Director for the California Telehealth Resource Center. We'd like to welcome you to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. And the webinars are presented on the third Thursday of each month. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started. Your audio has been muted, so if you have any questions, please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation, as well as a few during the presentation. Today's webinar is being recorded, and you'll be able to access today's and past webinars on the National TRC YouTube channel. Today's webinar is hosted by the California Telehealth Resource Center and presented by Kathy Chorba. It's my pleasure to introduce you to Kathy, who has over 20 years of experience with telehealth program implementation and management. Welcome, Kathy.
Thank you, Rebecca, and thank you everybody for joining us. I always wonder, people ask us, why do we create these resources? And this particular resource, Finding and Vetting the Perfect Specialty Service Provider, was created because whenever we do an implementation roadmap, webinar, or work group, we tell people now that it's time to start looking for specialty service providers, you need to start asking questions that work around your billing model. And they've always asked us, well, why don't you write these questions down and give them to us? So this is what we're going to do. It's in this webinar, and we'll also provide you resources as to how to download them. So basically, you need to know that finding specialty service providers isn't as difficult as it has been in the past. There are a lot of service providers out there, but the real trick is to find the one that will meet the unique requirements of your own clinic and your own organization. Because each provider and each organization will have similarities and differences in the practice and business model as they pertain to how they practice telehealth. So before contracting with any specialty service provider group, we do want to invite you to think about some of the questions that we're going to mention in this webinar and maybe incorporate them into your existing process for vetting specialty service partners. And also, if you need assistance, you can always access your regional telehealth resource center by going through the website, the telehealthresourcecenter.org. So within the telehealth implementation roadmap, establishing specialty service partnerships comes after you've already completed a thorough needs assessment. And in that needs assessment, you've already identified the specialties that you need, the volume of specialties that you think you're going to be referring to the partners. You've also identified whether you have clinician buy-in. Buy-in from the top, from administrative support, is also very important. And you've also identified who your telehealth team is. So now once you've done all of those things, now you can start establishing partner relationships. We did come up with 20 questions. And why did we come up with 20? It's not like we said we need 20 questions just because it's catchy, these 20 questions. Could there be more questions? Absolutely. Could there be less questions? I don't think so. So this document that we will share at the end of the presentation will have all of the 20 questions that we've discussed in the webinar, plus the logic behind the question. And as we identify more, we'll go ahead and update the document and repost it to our website. So let's get started, shall we? So first question you want to ask, and of course these questions are in no particular order, but I would like to think the first question that you would want to ask are, what specialties are available through this provider group? And why do you ask that question? Well, some specialty provider groups offer one specialty only, such as behavioral health, because that's what they specialize in. Other groups may be like dermatology, store and forward dermatology. But then there will be other specialty service provider groups that offer a lot of different specialties, including behavioral health and dermatology. So some clinics like the one-stop shop model, where for all their specialty needs, which really simplifies the contracting and credentialing, the referral process, the workflow. And other clinics prefer to shop around and find the best price for each specialty, and they don't mind working with different specialty groups. The next question you want to think about is, what is the billing model for this provider group? Does the group provide, do they contract directly with the health plans and bill the health plans directly? Or do they want to contract and bill you by the hour or by the block of time that you've reserved, or maybe by the number of patients seen, or a different scenario? Why do you ask this question? Obviously, because there are several different billing models used by specialists and specialty provider groups, and it's important to discuss these and establish a model that's mutually beneficial for both of you in advance. These items will help determine the financial model that best fits your program. And please do note, before you negotiate with your contract, you should know how many referrals you think you will have for each specialty and how soon you'll be able to start. Not only does that help your partner provider figure out whether they've got the capacity to accommodate your needs, but it also helps you in maybe negotiating price. If you can only refer one patient per year, it might cost you a little bit more than if you can refer 500 patients a year. That's the logic behind asking this question. The next question are, what are the specialty service providers' rates for live video? What are their rates for store and forward? And are they the same for adult and pediatric patients? It's a lot of different questions. Well, depending on the specialty services needed, as well as the volume and modality for each specialty, the rates may vary. And rates for store and forward specialties will typically be less or lower than live video specialties, and new patient appointments will probably be more expensive than follow-up appointments. So also the rates, they do vary according to the volume of patient referrals you anticipate sending to the specialty group. Keep in mind, if a specialty group bills by the hour, it's important to know the time required for new and follow-up patients, which we'll discuss a whole lot more in some slides down the road. And also, another thing to keep in mind is if the specialty group bills by the completed encounter, the rates may be higher than the hourly rate. Okay. So another question to ask is, what is the expected time frame that specialists will require for new and follow-up patients? Why do you ask this question? Is time frames vary for each specialty? For instance, when I was managing a clinic at one of the major universities, dermatology patients required 20 minutes, yet psychiatry patients required 1 hour. And new patients versus follow-up will also vary according to the specialty and the specialist. So most general rule of thumb, or most specialists require 40 minutes with new patients and 20 minutes for follow-up patients. But this is really important to know, not only for scheduling, but also when your billing model is to pay by the hour, because you're going to need to structure your appointment schedule strategy to ensure that you can financially afford the specialist time. So here's a question for you. When paying a specialty service provider by the hour, when is the $250 an hour specialist less expensive than the $200 an hour specialist? Well, if you're thinking of the answer is, it's when that $250 an hour specialist can fit more patient visits into that hour. Okay, so let's take a look at some sustainability spreadsheets. And I included this in this presentation because it's important, because these spreadsheets will help you determine the financial model that works best for your clinic, and it'll also help you determine whether or not you can afford to work with this one specialty service provider. So we've developed this using the model of purchasing blocks of time. It's difficult to develop models for every single scenario, but let's give just this one. It's for FQHCs and purchasing large blocks of time, say for instance 4-hour blocks or 8-hour blocks of time. And in this spreadsheet, which you can download and play with, and also contact us, and we will help you work through the spreadsheet. It's just very basic. It's not the end-all be-all for financial sustainability, but it is illuminating. And you would, for instance, in using the spreadsheet, you take a look at, you fill in the blue areas where you fill in the specialist hourly rate and then the number of minutes for the new patients versus follow-up patients. And then you fill in things like your PPS rate, the the staffing and overhead, your uninsured percentage of patients, the percentage of no-shows. And then once you fill in all of those blocks, the blue blocks, it will calculate the variance, which will show you whether or not this is a financial model that really works well for your clinic. And keep in mind that you can play with these things and say, well, gee, if we had with telemedicine, if we worked harder to reduce our no-show rate, would the variance be more beneficial for us? And you'll find that there's a lot of wiggle room and play in the spreadsheet to where you can determine whether this model will work for you or not. And also on our website, we do have examples of clinics that we have worked with in the past. So with these sustainability spreadsheets, you know when you're starting a telemedicine clinic, all the patients are going to be new to the specialist. So they're going to take more time to see, which means you're probably going to lose some money. Like in this example, you're losing $161 for every 8-hour clinic. And that doesn't look good. It looks very daunting. But you have to remember that as you move into more like the growth phase instead of the startup phase, the growth phase means you're going to be seeing a few more follow-ups in percentage in comparison to the initial visits, which means you're going to be able to fit more patients into this example of the 8-hour day, which then you look at the bottom line and the variance is $238. So that means you're not losing money in your clinic anymore. You're able to reach a little bit more where you're covering your costs and then some. And then you take a look at some of the more experienced and the advanced clinics, and these are the models that we're finding with the clinics that have done telemedicine for quite some time. We call this the maintenance phase. And this is where you're really able to manage how you schedule your patients into your clinic according to the specialist rate and the specialist required time for new patients versus follow-up patients, and keeping your no-show rate down a little bit and keeping your overhead costs down. Now you're able to more than cover the cost of operating this clinic. We've also included in this presentation the advantages and disadvantages for most of the common contracting models. This isn't really part of the 20 questions presentation, but I wanted to put this in here as information for you so that you'd be able to see when you are talking to specialists, you kind of get the advantages and disadvantages for everyone, not only the primary care provider, but as the specialty provider for each and every one of these different types of business models. And these are the most common business models. It is by no means an all-inclusive listing. So let's get back to the questions then. The next question is, does the specialty group have a credentialing policy or a preference for credentialing? And why do you want to ask this question? Telehealth, it makes everything difficult, doesn't it? By proxy or full credentialing will make a difference in how fast you can bring a specialist on board, and it should be established in advance. If you're billing on behalf of the specialty provider, you'll need to bring them into your 4 walls and you'll need to credential them at your site. Some specialty service providers will only utilize credentialing by proxy, while other providers will accept your wishes for full credentialing. So in addition, something else to think about is the specialty providers will need to be credentialed with the patient's health plan if you're billing on their behalf. And some providers are already credentialed with the health plans covering your site. The next question is, will the specialist or specialty group provide a bio of the specialist? Why is that important? Well, it's important because it's very reassuring to your providers as well as your patients to know the level of education and training and affiliations and board certification of each specialist. Are these specialists qualified to see my patients? We need to know. Let's see your bio. Let's see your credentials. Another question is, does the specialty provider group have referral guidelines for each specialty? So why do you ask this question? So referral guidelines are very important. They're a communication tool that specifies the time required for new and follow-up patients, as well as if or when a provider should be in the room during the consult. And finally, the information that is needed prior to the consult, which are labs or chart notes, and etc. This will be helpful to know the exact requirements, as they may vary from specialty to specialty and specialty provider to provider. Also, tests that are required prior to the consults can be very costly. Some providers require a lot of tests before the consult, which at times these tests are maybe unavailable in your community, or they're too expensive, or they're not covered by the health plan of the patient. So sometimes just knowing what the referral guidelines are, and if the requirements for tests prior to consult are so stringent, then that may be a provider that you might not want to work with. The next question is, who do you need to be in the room during the consult? So do you expect an MA, an RN, an NP, PA, MD? What is the level of provider that's required to be in the room with the patient during the encounter, and for how much time? So the reason you ask that question is some specialists will have a preference and may not be willing to let you determine who presents the patient. Some specialties like behavioral health don't require a provider in the room during the consult. So if you agree in advance how much time they will require staff to be in the room, that would be to your benefit. This is important to know, of course, for staffing, for scheduling, for billing, and budgeting purposes. For example, if an FQHC site is billing on behalf of the specialist, FQHC can only submit one bill per patient per day and not bill for the PCP and submit another bill for the specialist. In this case, the specialty service provider that doesn't require a PCTP, primary care provider, to be present in the room during the consult would be economically preferable. So does the specialist provide direct patient care or offer consultation only? These are really important questions, and it really depends on the clinic as to what's important to them. So direct patient care implies the specialty provider will make a diagnosis and a treatment plan and will prescribe medication that is independent from the primary care provider. With a consultation-only model, the specialist will send treatment recommendations to the primary care provider, who will be responsible for prescribing the medication. This is important to know, since you want to discuss this with your providers to see if they feel comfortable prescribing for a patient after only reviewing the specialist's notes and recommendations. If they don't feel comfortable doing that, then they might want to make sure that they work with a specialist that provides direct patient care, especially for psychiatry. That's the area that we find that a lot of primary care providers are uncomfortable with prescribing the medications that are associated with psychiatry consults. How will medication refills be handled? This is a good one. It's important to discuss who will be responsible and how will prior authorizations be handled. For example, if the provider operates inside your electronic health record and is using eScript, you will want someone to handle these refill requests and prior authorizations just as you would for any of your other providers in person. Another question will be, will you be able to utilize the same specialist that has already seen the patient, or does it just depend on availability? Why do you ask that question? Well, maintaining your relationship with the same specialist helps you feel confident of what to expect and also assures continuity of care as it pertains to diagnosis and medication prescribing, especially for behavioral health. And also, having the patient be comfortable and have formed a relationship with the same specialist is crucial for trust and compliance with treatment recommendations. The next question is, what is the turnaround time on charts being returned and how will they be sent? You should ask this question because you need to set an expectation up front with the specialist and hold them accountable to timely completion and transmission of all consult notes after the completed visit. This is not only important for the maintenance of provider-to-provider communication, for continuity of patient care, but for billing purposes as well. Some specialty service providers require the originating site to access their electronic health record to pull down chart notes for each patient, which is more work for the referring site, and others will agree to document directly into your electronic health record, but then that's more work for the specialty site. So it's important to have this discussion with the specialty providers. What is the policy on patient no-shows and cancellations? This is a good one, isn't it? That's a touchy subject. So why do you ask that question? Well, each specialist may have a different policy, and it's important to know upfront if you're able to cancel or reschedule patients and what the financial responsibility is. For example, If you're paying the specialist by the completed encounter, their tolerance for no-show patients will be so much lower than if you're paying them by the hour reserved, right? That only makes sense. It's important for you to set expectations for the specialist canceling due to other commitments. So the specialist may have recommendations for you for counseling clinics or counseling patients, but then you may have requirements and recommendations for them in counseling clinics if they can't make a clinic, and you might want to specify how far in advance you need cancellation notice, or if they do have someone that can take over the clinic for them. Is the referring site allowed or expected to overbook patients? I didn't think that would be a question, but my colleagues had convinced me that is a question, and it's something that comes up very often with our referring sites. So why do you ask this question? Is knowing there are often no-shows with patient appointments, most specialists will allow and or expect you to overbook patients. It's important to establish what you mutually agree will work and will not disrupt the practice and the telehealth clinic. I want to ask, what is the protocol if or when patients do show up? If you double or triple booked your clinic, now what happens if everybody shows up? Will the specialty provider be able to give you extra time in order to see all patients, or will you need to send some of the patients home without being seen? You should also discuss how payment is scheduled or structured. Some specialists that charge by the hour may charge you for the full hour regardless if you have patients no-show, or some may allow you to have primary care provider time and have the primary care provider step in and get a second opinion on other cases. Then the next question is, what is the emergency backup policy or plan for technology failure? Why do you ask that question? It's important to ask this question and to discuss technology backup, because technology failures will happen. It might not be the equipment. It may be the equipment, it may not be. It may be your peripheral equipment, your scopes. It may be your telecommunications line. It could be the power goes out. Anything can happen. Technology does fail. It's not 100% foolproof and fail-proof. So what is the procedure that the specialty service provider follows should the video conferencing disconnect during a session? How many attempts to reconnect should you make? Should you call the specialty service provider's office? Will they contact your coordinator? What is the process for finishing the appointment or rescheduling the patient should you not be able to reconnect? Some people just pick up the phone and continue on with the consult, but whether that's a billable event or not, you'll have to check with us. All specialty service provider groups should have some sort of a policy for technology failure. And what level of technical support will the specialty provider group provide? No, they're not in the service of providing technical support, but it kind of behooves them to provide some small level of technical support in case something goes down. Most primary care clinic sites have some level of technical support staff available, but very few clinics have staff that are available to troubleshoot telemedicine, video, and peripheral equipment and or broadband connectivity for video transmission. This is something that is very highly specialized. Some specialty provider groups do provide a basic level of technical support or troubleshooting assistance in order to make sure that the services are provided as scheduled. So what's the next question? Can the referring site provider call or video conference the specialist before or after this consult? So why do we ask that question? Sometimes there may be a need to speak to the specialist without the patient present. You should ask if that's acceptable and if there's a cost associated with that. How will the staff communicate with the specialist during the visits if they're not present in the room with the patient? That's a really good question, isn't it? It's more logistical, but it's something that you need to iron out before you start your consults. You need to address what type of communication, whether it's text or email or telephone, that is expected when either the staff has a question or if the specialist needs the staff to step in the room at any time during the consult. And this information is useful in order to provide the coordinator the proper tools for a smooth flowing clinic. And oftentimes the clinic coordinators are not issued cell phones for text, or the room where the telemedicine equipment is located isn't near a nursing station that's equipped with a desk phone or a computer that will enable for email or phone call communication. So ironing these things out before the consults start is very important to make sure everything flows smoothly. What type of correspondence is acceptable between the referring site and the specialist? So what you want to do is discuss if calls, emails, text messages, or flags in patients' charts are acceptable, and can these items be communicated directly to the specialist or only through a third party, such as the provider's scheduler, coordinator, or receptionist? And what is the onboarding process for new clinics? So why do you want to ask that question? Onboarding is hugely important. Specialty service provider groups may provide some, if not all, of the following. They may provide training on patient presentation techniques. They may provide training on the referral process or equipment usage or video, or they may provide video meet and greet sessions with the specialists and the referring providers, or some other onboarding process where they'll provide forms or training on how to access the electronic health record on their end, or you provide training for them. Some or all of these may be no cost to you, but others may come with a small charge. And so it's important to figure this out up front before you're stuck paying a charge you didn't budget for. So when you think about it, these are 20 basic questions that you want to think to add to your repertoire when you're trying to add a specialty service provider that is going to be providing services via telemedicine. So again, what specialties do you have available? What is your payment model? What are your rates for new and follow-up appointments? What are your appointment times for new and follow-up appointments? And what is your credentialing policy? Do you credential by proxy, or can you go through full credentialing? You want to make sure that the specialists are qualified to see your patients. You want to make sure that there are established referral guidelines so everyone is on board with which patients are appropriate to be seen via telemedicine and what the chart notes are that are required to be sent prior to the consult. You want to know the staffing requirements. Who's required to be in the room and for how long? You may not want to work with someone that requires a primary care provider to be in the room for a full hour and a half, when maybe 15 minutes at the beginning of the consult or 15 minutes at the end of the consult would work better for you scheduling wise and financial feasibility wise. You want to know if they're providing direct care or patient consultation only. Again, for direct patient care, they'll probably do the prescribing. And for consultation only, primary care provider will do the prescribing based on the specialist recommendations. You want to know who's going to be responsible for medication, also medication refills. You want to know if the patients are going to see the same provider time and time again, or are they going to see a new provider every time there's a follow-up visit. You want to make sure that there's some level of continuity of care. The turnaround time for chart notes, you need to know what happened during the consult in order to help you with billing, but also to communicate between the primary care provider and the specialist about the patient's medical condition and diagnosis and treatment. Cancellation and no-show policy for both ends as far as a primary care site. How soon can you cancel a scheduled time with the specialist without being penalized, but also you want the specialist to understand if they need to cancel a clinic, what is the time frame in which it would be acceptable for you, because you as a primary care provider are going to need to reschedule all of the patients into another clinic. You want to talk about patient double booking. Is that acceptable? I think it is acceptable, but is it something that they recommend or not? And then what's going to happen if every patient shows up? Is that provider willing to stay a little bit longer to see all of your patients? Also, you want to know if there's a backup plan for technical failure. If technical failure happens and you're paying by the hour and not by the patient seen, you just paid for nothing. If you're paying by the patient seen, then the specialty provider is not going to be very happy because this is not a billable event. You want to know what the non-consult communication policy is. Can you talk back and forth with the specialty provider, or do they not want to hear from you? A lot of providers welcome communications with the primary care providers because these are your partners and not your vendors. Method of communication during consult. How do you pull somebody in the room if you're done with the patient? How do you get the coordinator back in the room to change patients out? Or how do you call somebody in if you're having an emergency or technical difficulty? Post-consult correspondence policy. How soon will you get the chart notes back? And also the onboarding process. And those are your top 20 questions. Oh, I think we should probably add one more as I'm thinking about it, which would be something in reference to malpractice insurance. So you should be thinking about that too. What level of malpractice insurance does that provider have that you can work into your contract? So all of these questions are in our infographic, the 20 questions to ask a specialty service provider prior to signing a contract. And along with the questions, we'll also have the logic behind why we ask these questions. So to download the 20 questions document, you can visit our TRC website's resources page at caltrc.org. And on our website's resources page, we also have a lot of other resources, which include the things that were listed on the implementation roadmap at the beginning of this presentation, which are a needs assessment, the various staff roles for starting a telemedicine program, considerations in developing partner relationships, which is the 20 questions document. Also, you'll find the sample telehealth sustainability worksheet, which you can download the Excel file to where you can play around with the different factors. How much am I paying a specialist? How much time for a new appointment versus how much time for a follow-up appointment? How many patients can I squeeze into a 4-hour clinic or an 8-hour clinic? And on down the road to where you can be able to get a good basic idea as far as sustainability. It's not the end-all be-all, but at least it's a great start. You'll be able to see the contracting model, pros and cons, credentialing guidelines, billing guidelines, sample referral guidelines, all of the things that we talked about in this 20 questions, along with other forms and sample workflows and other documents. So you want to think, now that this seems like a one-sided presentation, doesn't it? The 20 questions that you should ask a specialist prior to contracting with the specialist. But on the flip side, there's another document that we are working with some of our specialty service partners to be able to say, how do you keep a specialty service partner happy? Because that's important, don't you think? Once you get the perfect partner on board, that's not the end. Now you need to figure out, how are you going to keep them happy? How are you, as a primary care provider site, going to keep the specialists happy and make sure that they have all the tools that they need to do the job and do the job well? So it should be equal on both sides. So stay tuned. We will be developing this document. We will be presenting it at our Telehealth Summit in May in San Diego, but we will also be posting it on our website probably this fall. So all thoughts and comments on this topic are welcome, not only for the 20 questions to ask a specialty service provider, but also thoughts about, how do I keep my specialty service provider happy once I have them on board? Please contact us. We're your resource center, but we can't be a resource center unless we get input from those of you who are also experts in the field. So contact me, Kathy Chorba. My email address is at the bottom of this slide, chorbak@ochin.org. And just to let you know, we are here for you as the Telehealth Resource Center, as well as anybody from the National Telehealth Resource Center. But this is our team with the California Telehealth Resource Center. I'm Kathy Chorba. You met Rebecca Picasso. We also have Aislinn Taylor, who is responsible for all of our training and outreach, and Jeannie Russell, who is our project coordinator. Please feel free to contact us at any time. And I want to thank you so much for your attention and bearing with me through this long presentation.
Thank you so much, Kathy. I want to remind you guys that we have a little bit of time now to do a Q&A. So if you have any questions to ask Kathy that she'll answer live, please feel free to type them in the Q&A box. Kathy, we do have one question right now. It says, can this also be instituted in the inpatient hospital setting?
I think it can. It absolutely can. I'm just trying to think through all of these questions. If you do want to contact us, we can go through each of the questions and figure out which ones work and which ones don't for inpatient. But I'm thinking, Rebecca, I think you should probably agree with me that absolutely yes.
Yes, I do.
Okay.
All right, I'm just going to give you guys just a few more minutes, see if there's any other questions that come in.
Great. Well, this is short and sweet. We know that it's hard for people to hang on for an entire hour and listen to people drone on and on just for the sake of soaking up time. So, like we said, please do contact us at any time, and hand it back over to Rebecca.
So thank you everybody for attending. This presentation has been part of the National Telehealth Resource Center's webinar series. The next webinar is scheduled for February 21st and will be presented by the Center for Connected Health Policy and GP Track on federal and state policy updates for 2019. Those include CMS changes and state level trends. Join them as we discuss Medicare telehealth policy changes, Medicare Advantage plans and telehealth, the latest on telehealth and substance use disorder, developments on the state level, and information regarding FQHCs and RHCs. Registration and further information will be sent out soon. We value your opinion, and we ask that you maybe take a few minutes to complete the online survey. They will open immediately following this webinar. Again, thank you so much for your time, and have a wonderful day.
All right. Thank you, everyone.